My name is Judy Blake, and I am the Leadership and Advocacy Coordinator for Family to Family Network. As I mentioned, this will be the first of our series of presentations, and I'm honored to present Dr. Eric Storch with Baylor College of Medicine, presenting on autism and anxiety, what's the connection?
All right.
As a single parent of a young adult with autism and other co-occurring disabilities, I personally found this a very fascinating topic. Dr. Storch, if you would like to go ahead and present and share your screen. If everyone could hold their questions until the end and write them in the chat box, I'll go ahead and monitor the chat box for him. There will be a survey at the end. I've already posted the link. Please, please make sure that you take that survey. It's really, really important. Thank you so much. And Dr. Storch, please take it away.
Cool. Well, Judy, thank you so much. This is great to be here. Feelings are completely mutual to you, and thank you everyone for really taking your time out. One of the things, you're seeing the presenter view. Oh my gosh, look at this. But wait, I figured out how to do this. Swap. Okay, golden, right?
Yes.
So the beauty of Zoom, of course, is you figured out stuff like that, which ordinarily would have taken me forever. The other is that you get to see people do really funny things. So last time I did one of these, someone apparently thought that if they couldn't see you on the video, you couldn't see them picking their nose. But you actually could, which kind of cracked me up the whole time. So, today we're just really gonna talk a bit about anxiety. I'm a clinical psychologist by trade, and one of the reasons why I really love doing talks like this is it's all about the community that we create, and the network, the connections that we have when, you need, someone who can do this, who do you reach out to, or where do you get that information? And so having that opportunity to be a part of that is really important. At the end of the slides, my email's on there. One of the joys of not having any life, which quite honestly isn't that much different from before COVID, is I really want to be here and try to connect folks in the right directions, whether it's something we're doing or something otherwise. The other thing I'll say is a lot of our research is sort of consumer oriented, meaning we do a bunch of stuff that NIH funds that's kind of like really researchy. But then we also do a lot of stuff that's funded through, for example, the Texas Higher Education Coordinating Board, where it's all about how do we give more family services, but how do we monitor how well those services work. So these are some disclosures that we're always kind of counseled to put in there. I did come back. The one from Lauren Zerbaum, I recently got a negative royalty statement of $27, which I felt like that was kind of messed up. They should have just not sent me the letter. But those are for books that no one reads. And then a big part is really our team. And our team, are people, who are part of this. Sarah Weinzimmer, who's one of our incredible coordinators, and it really actually isn't on our acknowledgement slide, is outstanding and is in charge of one of our projects. But we really have a whole group of people that we're working with, and then a whole even bigger group of families that are kind of part of our efforts to nerd out. So today there are really a couple goals. So the first is talking a bit about anxiety in kids on the spectrum, and then talking about what are ways that we can effectively intervene with anxiety. So many of our projects involve engaging the family in sort of being their kid's parent, being their kid's therapist, their parents too. But we want to figure out how to take some of our therapeutic approaches and make them more accessible, accessible, but also even more effective and more kind of tailored to each kid and their particular needs. Now, we all know this slide. Every time we sort of turn around, we see CDC coming out with rates that seem to be increasing. About 1 out of 50-ish kids have ASD, more boys than girls, and we're all very clear about some of the challenges that are associated with age ASD and characterize the condition. We're seeing diagnosis usually pretty early on, but this is another kind of area where we need to improve upon. One of the things that I'm really excited about is we just got a great score in an NIH grant where we're going to start looking at different types of kind of effective computing or automated ways of looking at different characteristics of kids on the spectrum relative to typically developing kids, to try to understand, are there some more subtle nuances that we can pick up on that will help us diagnose even more early. So if you think about your iPhone and the facial kind of recognition feature, it's really taking that technology but doing it in a more interactive fashion with other people and in kind of a continuous fashion. So again, symptoms appear early. We want to catch it as early as we can so we can do stuff to kind of help it out. Now, when you ask families of a kid on the spectrum what their concerns are, one of the first concerns is how is my kid going to do now, but also in the future, especially when I get older. But another concern involves these kind of psychological psychiatric manifestations. Disruptive behavior being a common one, and anxiety and OCD, a true OCD, being another really kind of common feature. And there was one study a few years back that actually had parents endorsing anxiety symptoms as the second biggest concern with regards to their child's functioning. Now, there's some evidence that as many as about 3/4 of kids experience anxiety, and probably that sweet spot is about 1/2 to 3/4 overall. And we'll talk a little bit about some of those presentations in terms of how we may see anxiety symptoms and ways of sort of disentangling anxiety from other kind of core ASD components. Now, one of the other things we'll talk about is that interaction with anxiety and ASD and how it really, sort of becomes a multiplicative effect where, it's not 1 + 1 = 2, but, sort of 5 × 5 = 25 and makes the overall presentation more challenging for the youngster, but also the people that love her or him. So if we think about anxiety, there's good and bad types of anxiety. If we're hopefully all, thoughtfully walking around wearing masks, kind of keeping our distance and so on, like that's a good level of angst. It keeps us safe, keeps us alert. Over the years, I've sort of lost my anxiety in work where it's like, that chapter's due in a week. Well, that week really means in like 3 months from now. And the anxiety I felt like I have to be on time, 20 years ago, I think I need to bring some of that back into play. But there are parts that are good. My wife jokes that the minute our first child was born, she developed generalized anxiety disorder and just became this worrier. And I just sort of sit there silently nodding because I know that that's really the right response. I shouldn't say anything at all about that. But like it's kept our kids relatively healthy. It's kept my son relatively clean. I was reprimanded last night that my theory of showers, which is that the shampoo washes down your head, down your body, and cleans the whole body, is not an acceptable way of really having a 10-year-old boy clean oneself. I disagree personally, but like I guess that keeps them clean and without different forms of like fungi, but good stuff. The bad stuff is though where we're worried. It's where there's excessive there's impairment, where people can't do stuff because of their anxiety. It's kind of a simple way to put it, but really like how we target different features, and that's what we're talking about here. So when we start breaking it down, we see that somewhere about 30 to 40% of kids on the spectrum have a clear anxiety condition. And some of this is kind of moderated by certain features like age. So for example, with social anxiety, suggesting 3 out of 10 kids on the spectrum have this. We know that as kids get older, this rate just shoots right up, especially when kids tend to be more high functioning because they recognize that the way that they're engaging with their peers or how their peers see them is a little bit different, and yet they kind of struggle to keep up with it. So we see much higher rates there. With our little ones, a lot of difficulty with separation. So I can't tell you the number of times I've talked to a mom who, like a vacation, her Calgon moment to kind of, age date some of us, is, like going to the bathroom without a kid, like attached to her. But you see that piece. We see a lot of excessive worry. And some of this kind of bleeds in to the overall presentation where a lot of worry, well, what are we going to do next? What's my schedule looking like? How do you contend with change in that schedule and so on? And then finally, with OCD, we're seeing a lot of like true kind of obsessive compulsive symptoms. So we're not talking about someone who's engaging in stereotypies or someone who's, just likes things lined up in a certain way. We're talking about this relationship between these intrusive thoughts and kind of repetitive compulsive behavior or avoidance coming in. I saw someone the other day who, it was kind of interesting. They were an adult who were afraid that something could fall from the ceiling on their hair and damage their hair transplants, which, in the back of my mind, I was sort of thinking like, might not be a bad thing, but you go with the person where they're at. But what for them was really relevant was that they would walk along the corners of rooms to try to minimize the impact of anything falling. So you can't see in my office, but there's an air vent there. That would have been a big trigger. So a lot of times we see these very kind of idiosyncratic worries that come into play, but really are impairing and debilitating for the person, and warrant intervention. Finally, a lot of phobias, and so all the kind of common friends or enemies, being afraid of sleeping at night, um, is one example. Uh, Bugs, dogs, animals, injections, dentists, all these things are relevant. But what I see happen quite a bit in kids on the spectrum is that those fears tend to escalate even greater and really result in high levels of impairment. So, for example, a kiddo who can't go to the dentist, I mean, this is a big deal, ranging from the inability to get proper dental care, just as an example, to if you do go, you got to knock them out, which then confers these additional risks of putting a youngster under anesthesia. So lots of different ways that anxiety comes up and really can be impairing. Now, just a few slides on sort of how I think about these types of conditions. And with GAD, it's really this like these excessive worry warts. They worry about everything. So lots of different things, lots of stuff, now, but in the future, excessiveness in the worry. I'll bring up 2 examples of kids that I've had within our trials. One was worried about which college they would get into, and they were 7. So on the one hand, we certainly want to congratulate that, well, not really encourage, I'm being sarcastic, but it was a 7-year-old who was worried about, can they do this, this, and this to get into Harvard? Okay. Another was a kiddo who was afraid of running out of gas. So they couldn't go below half a tank. And the child had the gas stations mapped out all along the highway at every exit, which was pretty impressive when you think about how much work that took. But it was all in kind of the way of relieving this angst. See lots of somatic stuff come into play: tummy aches, headaches, having to pee, sleep problems, food, eating problems, and again, a good example of where kind of the change in environment or routine or novel situations can really interact and make this issue more concerning above and beyond. Across all of our anxiety conditions, it doesn't just affect the young person with this, it brings the whole family into play. And it's not just because, we love our kids, it's because there's a lot of stuff like questioning and reassurance seeking, avoidance, having to do stuff a certain way. And so all of these features, while, as parents, we sort of do them because we have to get through the day and, support our other kids, or just literally make it through the day to start the next. It ends up kind of feeding into the condition and becoming a challenge. And so we sort of, want to bring in, not sort of, we absolutely want to bring in parents to help them learn how to help their kids. Now, with separation angst, this is normal with little ones. As the father of two daughters, I'm frankly trying to encourage this, although my 12-year-old seems to really want to get away from me for some strange reason. It's characterized by this intense fear of separation. And a lot of times we'll see this come in the form of just things having to be a certain way in terms of the family routine, and having people always around. Uh, this tends to evolve over time and move away from separation anxiety, but it has it's sort of a kind of diagnostic, evolutionary component where it stops becoming separation anxiety and then evolves into other worries over time. So the diagnosis may go away, but the overall presentation tends to kind of escalate and broaden. Now with OCD, I'm always this is where I started my work, um, and it was interesting, 20 years ago where the field was and where it's come. OCD is a very kind of serious type of condition, and the key part are these intrusive, unwanted, distressing thoughts. Now, a lot of us think of OCD in terms of stuff like contamination worries, or germ worries, or symmetry order. And that's true, but it can also involve these really scary thoughts. Some of them can be stuff like, I'm afraid I could kill you. I have a kiddo who came in who was afraid that they would rip the ears of their dog off, even though they love their dog and they would never do that. Or it can involve private parts. I'm afraid I'm going to reach out and grab people's boobs. Oh my God, I don't want to do that. But these unwanted thoughts that keep the person engaged in rituals, where the goal of the ritual is really to reduce the chance of the fear happening. Um, and with ASD, it's sometimes a challenge in differentiating it. One of the best ways of doing that is really to understand, does the child like it or not? So a kid who's obsessed with video games, they like it, they want it. Whereas a kid who's really kind of obsessed with catching COVID, they tend to be more upset by it. And so differentiating kind of that level of distress and intention, and are they seeking it out versus are they trying to stay away from it, is really your key in distinguishing this. All right. Now, social anxiety is just what it sounds like. It's this concern about being negatively evaluated or judged or made fun of. Could be as narrow as certain situations, like performance situations, like giving a talk, or it could be more broad across all social situations, which we tend to see a bit more of. And as you said earlier, as this kind of self-awareness starts to come into play with age, some of those kind of differences and interaction also become more kind of aware, and that's why we see this kind of escalate over time for kids on the spectrum as well as typically developing kids. One of the ways of distinguishing this from ASD is really that, similar to OCD, is that interest, that desire to kind of engage. And so when anxiety is impeding that desire or that ability to, that's when we start thinking of social anxiety. What's a little different is when there's absolutely, there's less interest or not interest in play, then we think less of it in that social anxiety realm, and more kind of characteristic of ASD. So again, that volitional nature helps us distinguish. And then phobias, as we've talked about. One of our differentials there, though, could involve sensory aspects, and it's not an either or. It's very much a and. So we know we've been doing research in a construct called misophonia, which involves this kind of selective sound sensitivity that results in this very aversive emotional reaction and then behavioral response. So what we see is that there's heightened rates of this in kids with ASD. And so it really is a good example of how, these certain kind of stimuli can come into play and make something that's feared even more kind of pronounced. And there are multiple examples kind of this scenario. So why does anxiety come out? You know, Overall and in kids, on the spectrum. The short answer is we don't really know. We've started doing some work in genetics, and what we see is that the hit rates for whether it's OCD, anxiety, or ASD, it's all over the place. So ASD, uh, it seems to change relatively frequently in terms of what we know, which is that so many cases tend to be unaccounted for genetically. And so we're getting better at understanding, but there's quite a few. The majority of presentations tend to be idiopathic. So there is a piece, but we again just don't know. Now there are other factors too. Hereditary matters, but not completely. I think behavioral stuff matters a lot. So whether it's you know kind of the behavioral response that people have, like if they're afraid of doing something, they stop doing it, which makes them feel better, but makes them more likely to do it that way the next time. That's a big one. Or seeing your parents respond in a certain way, that's a huge one. Different stressors can aggravate anxiety, and the way we perceive the world can also aggravate anxiety. So take COVID as an example. It's awful in every which way, but some people are struggling more versus less with the emotional aspect of it. And so again, it's the same environment, but how we perceive it can have a significant impact on how we feel about it. Now, the interaction with ASD is really a critical one. So everything becomes a Venn diagram, and in terms of massive levels of overlap. And when we think about how we diagnose psychiatric conditions, it's in terms of a classification where a person meets these criteria and they have this, and it's a little more nuanced, but it's very categorical in nature. But the reality is that it's not really that way in the real world. Now, with ASD, we see anxiety confer additional impairment above and beyond what you might experience or expect alone. So, on the one hand, when you have a kid who's anxious, we're seeing much greater rates of repetitive behaviors. We're seeing higher challenges with sensory problems, and at the same time, also this kind of difficulty in functionality, whether it's at the family level, the school level, peer level, or academically. But anxiety on top of ASD really complicates the overall presentation above and beyond just having one or the other. So the question comes up of what do we do with this? Now, there are a few different options. So one of the first, or one option, and this is kind of an interesting one, but there are different medications that could be helpful. Now, in kids without ASD and anxiety, what we've seen is that there are antidepressants that have been shown to be effective. So sertraline, fluoxetine are two very well-studied ones. Sertraline has an indication in OCD and generalized anxiety disorder. Fluoxetine has one in OCD. But when we look at this in terms of kids on the spectrum, there are very few data out there. So in fact, a couple trials did compared medication, in one case fluoxetine or Prozac, to placebo, and found that they didn't separate. Now, one of the challenges with that study was they sort of grouped anxiety and repetitive behaviors, which could be a stereotypy, together. And I think their outcome was just poorly chosen. But the evidence from a kind of a clinical trial standpoint is limited. I think from a standpoint of what we see in the real world, there's certainly good evidence, and this should be an indicated intervention when people's anxiety is very significant. But there's a lot that needs to be done in terms of our next steps for understanding kind of the placement of antidepressants. There's also a question on safety concerns where we need to understand more about safety as well, well, period, leave it at that. And safety, I mean more in the kind of acute framework. So from a psychotherapy standpoint, we do it a little bit differently. So I can't believe how much hair I had then. It's like unbelievable. But this is how when I trained in New York City, it's kind of how we thought of psychotherapy. Like, someone sits on a couch. What's funny is that's how I sleep. Like that's my 12-year-old now, with my arm above my head. Genetics can be amazing. And then we blame the mom, which isn't really the case. Um, but therapy is really very different. It's very concrete and behavioral and skills based in terms of developing really kind of therapeutic acumen to help your kid. When we work with kids, it's really, really important that we're working with the parents and not in like the kind of dry cleaner model of therapy, which is drop your kid off, go away for 45 minutes, come back for a 5-minute check-in with your kid freshly laundered. It doesn't work that way. We want to teach parents how to deal with this stuff so that, on Saturday night when we're at the club, like you're dealing with the problem, not bugging me. And I haven't been to the club in a while, for the record, but that's kind of our mindset. Now, cognitive behavioral therapy is one of the most well tested interventional approaches for kids on the spectrum or kids who are typically developing. Now, I'm definitely feeling old here, but from the standpoint of kind of history, when I first started, we we're really working on how do we establish how well something works for OCD and kids and adults, but mostly kids. And what we saw were that there was a group of kiddos who were on the spectrum who really did poorly. And so what was interesting is that this translated into, in 2009, we got our first NIH grant in this space. And then that led to our second one that last year we published sort of what's kind of the conclusive study on does CBT work when we personalize it to kids on the spectrum with anxiety? And the answer was yes, it did work wonderfully. And it was better than just if we took like a non-personalized CBT approach. And so now we're at this point of starting to get it out there in the real world. Like we did it in a lab setting. But the whole nature of CBT is really based on this kind of interactional model. So that it goes to the way we think about things and how that kind of thought perceives how we feel and then what we do. So if you take it like this, my 5-year-old is afraid of dogs, and so if she sees a dog, her first thought is that dog's going to jump on me and hurt me. Then what does she do? Well, she feels anxious, and then when a dog comes, she stays away from it. Now the joy, I mean, this is like a huge benefit of being a psychologist kid, is that when she's with me, what I do is I call the dog over, and we sit there and play with the dog until she's like comfortable and having fun with it. And then I bill myself, and we go out to lunch. But that's kind of our model of treatment. We want to think about the way people interpret stuff, and then know the emotional reaction, but also how they behave. But we want to intervene in that cycle and disrupt that cycle. So the core components, if you're thinking about whether it's for yourself or whether it's for a kiddo that you serve, but the core components are really severalfold. One is this idea of exposure therapy, and exposure is not mean, but it's sort of about facing the fears in a gradual, systematic manner. If anyone's ever read that book, Going on a Bear Hunt, which as a kid, I loved that book. And then I started reading it to my own kids, and I realized like how awful I was to my parents for making them read it to me over and over again. But the whole concept of this is a family that's going on a bear hunt, and they come across obstacles and they can't go around it or under it or over it. They just got to go through it. And that's what we teach about with anxiety. But we want to do it as a family. Because we know that kids in general don't like to feel anxious, nor do parents, but that parents have their kids' best interest in mind, and we need to engage them as our partners in this process. And we also need to teach them how to deal with the fact that anxiety is hard, but it's not going to kill your kid if they have to experience it. So we want to also build out that kind of skill set as well. Now, there are a few other things that we do. So sometimes we'll do cognitive restructuring, which is sort of like being a detective against anxious thoughts. And we teach parents and kids how to make sure anxiety kind of stays away and they can, live the dream. Now, the educational piece is all about helping to recognize anxiety, helping to understand that avoidance or rituals kind of screws up everything. So we don't want to do that. Um, and learning again how to more directly confront fears. We try to keep it simple and use concrete examples, including social stories, but be parsimonious in our approach. What I love about partnering with parents is that they know their kids' language, and so it can often help kind of decipher it or make it more palatable or clear when we're talking about why when you jump in a cold pool. If you get out right away, that pool's going to be cold the next time you jump in. But if you stay in and swim around, that it's going to feel, warm as you stay in there and warmer as you get used to it. So we want to teach everyone why we're doing what we're doing. And then the first step, especially with our older kids, involves just kind of thinking about anxious thoughts and how we can kind of identify them, but replace them with more realistic thoughts. And the big thing I like about this cognitive piece is it builds a narrative around the exposures, which I'll talk about in a minute, and what that means. We'll try to get people to relax. One of my favorite DVDs or CDs is a kid-friendly kind of progressive muscle relaxation where kids pretend like they're various animals, like a turtle trying to tuck your head into its shell. But that kind of alternating between tension and then release of that tension can be really helpful at relieving stress, especially nighttime. We'll want to model brave behaviors, and I love the Charles Barkley comment, but like really rewarding adaptive brave behavior, but making sure as parents we're very mindful of how we're presenting, and that we can kind of demonstrate what's a healthy way of approaching different fear situations. And then for me, I think well, empirically, the most important component, and for me, is this idea of exposure therapy. And it's about gradually facing fears without escaping from them. So if you think about anything that has ever made you nervous, if you ran away from it, it probably still makes you nervous. But if you kind of face it, and if it's a big fear, you break it down to small steps, it gets easier and easier. So when I started my career, I was really, really nervous about presenting in public. And frankly, I sucked at it too. But I kept doing it because I knew I had to do
That
it.
is not true.
Well, I'm like super old now. I've been doing this a while. But back then, I was not good. But there were a couple of things that happened. And thank you for that vote of confidence. One of them was that I saw my mentor, who I really looked up to, give a talk, and literally the only thing that would have been worse is if he pulled down his pants and went to the bathroom in front of everyone, because it was the worst talk ever. And then everyone clapped, and I'm like, oh, that's not so bad. And then I did it again and again, and realized it usually goes pretty well. And then I had a couple times where I totally screwed up. Like once I was giving a keynote in California, and I flew out in cargo shorts, and I was going to take the red eye that night in cargo shorts. And I went to unpack my suit, and I didn't bring any pants. So all I had to be picked up at like 7:45 were cargo shorts. And what I love about California is like I was so embarrassed, and people are like, "Yeah, we didn't even know. You just look cool." And so, all right, but like nothing really bad happened, and so that's kind of the other piece that we're doing with exposure. It's that idea of if you face your fear, does the feared outcome happen? And if it does happen, is it really that bad? In most cases, it's not. And we start with easy things, just like I want to start, training for a marathon by running 26 miles, start by running a mile. And we kind of build up in that regard. But this is kind of our core component of what we do in treatment. We rate our distress to make sure that we have a sense of kind of where where people start where they end. And we build it out in a step ladder. So there's a step-by-step approach to this that's paired with different rewards. As we said, it's all about kind of learning about the feared outcome, but also that the kiddo and the parents are able to deal with it effectively. Um, and, and then finally, relapse prevention. One of the reasons why I love kind of partnering with parents on this is that, you want to be on the speed dial. So our goal is that the only contact we have in the future are kids, prom photos and so on, where I am sort of dismayed that they look infinitely better than I looked when I was that age. But nonetheless, like it's, to stay in touch if a problem does arise, like what do we do? How can we brainstorm ideas? And if needed, re-engage and help or support. Now, there are a few protocols that were adapted for kids on the spectrum. The two that we actually use the most, one is Cool Kids ASD, which is based out of Australia. And then another is BIACA, sort of like the mouthwash, that stands for Behavioral Intervention for Anxiety in Children with ASD, which is what we've really tested in our NIH-funded work. Challenge a little bit with BIACA is that it's a little less conducive to like a real world clinic because it takes a little bit more time. But the core components of facing fears are all identical. Now, there are a couple projects where we've started to kind of take what we learned in the clinic and try to bring them out into the real world. Now, one of my close friends and colleagues, a genius named Allison Salome from Tampa, where I used to live, we had a project that was involving kids with PTSD, and they were young kids from ages about 3 to 12. And what we did was we created this kind of step model to treatment. And so the step model involved a small kind of dose of help, and then for those people that needed more, we gave them more. So it's all about giving people exactly what they need, as opposed to a one-size-fits-all model. And so we took that and we applied it to working with kids with anxiety and ASD. And so the study is funded by the Higher Education Coordinating Board and sort of looks like this, where we provide parents sessions on how to help their kids. And then if kids are doing great, awesome, we assess it and then we stay in touch. But if the kiddo is struggling, then we go into that more standard, here's what therapy would look like. And then we assess those things. What I love I love the study because everyone gets help. And this point isn't a random assignment. It's more of okay, well, you need more help? Great, you get more help. And it's all free of cost, which I sort of like that type of thing. I believe mental health care should be accessible for everyone, not just people who are really rich. And then another project with my very close colleague and friend, Sophie Schneider, who's on faculty at Baylor here, looks at different types of telehealth therapy or different intensities for kids on the spectrum with anxiety. And so we're doing it in kind of this Zoom format, which I think we're timely because we started this before COVID. But we're looking at this relative to a less intense model. Now, what we've seen is that there are a lot of parents who are so attuned to their kids. And frankly, they're like, if I could hire them to be part of our therapy team, that'd be great. But then there's some parents who maybe have that same skill set, but they're overwhelmed or tired or have 3 other kids to deal with plus a job. So we're trying to understand for whom we can have a lower level of treatment to be successful and who needs something that's more intense. The idea isn't to shortchange anyone, but rather it's to be thoughtful about the different challenges that we have in actually meeting all the needs of all the kids in Texas. And I think we could produce a lot more kind of, a lot more therapists and still be challenged in that regard. And so Sarah's email is listed here if anyone's interested for themselves or or clients or whatever it is. And then this one also is free of charge. One of the other projects that Sophie and I just had funded was oriented to trying to develop an internet-based CBT protocol that would be freely available to everyone in both Spanish and English. And so again, trying to really disseminate information and make it accessible for everyone. Now, what our research says is when we think about behavioral therapy for anxiety, it really works well. In that kind of seminal study I talked about, we ended up having about 90% of our kids get a lot better. And it was a pretty real sample, not kind of where we pick and choose who we thought would get better at the beginning. So most kids are doing well. There's some evidence that it might take a little bit more or a little bit longer, and that gains might be a little bit more slippery than a kiddo who's not on the spectrum. But that remains to be seen. That's just more my clinical assessment. And there are other pieces too that can help. Social skills can be helpful, though generalization's a challenge. Gender and age don't seem to matter too much, particularly gender, although we're learning more about how girls with ASD present differently than boys. And I think this could yield something, kind of a different conclusion, in the near future. And then this one's a huge one. Parental involvement is really critical for making sure our kids do well in treatment. Other limitations, hit on some of these, like how long do gains remain? What do we do if someone doesn't get better? And that a lot of our studies were done in kind of primary Caucasian kids. I'm excited because some of our work now will absolutely challenge this, where we have a sample that really represents Houston's diversity. But how do we work with kids who, have cognitive functioning that, is a little bit on the lower end? Can we work with parents effectively? And then for me, a big question is, how do we remove kids off medications if they've been on them with partial response or no response? Can we use behavioral therapy to really help? Now, with regards to COVID, a couple last kind of statements. One of the biggest things I think we can think about is trying to maintain, a routine, even when there's a disruption routine. The uncertainty has, I think, been one of the most challenging pieces, around all these things. But it's, trying to introduce certainty within a setting can be really helpful. Bring out visual calendars, recreate new routines, and engage in structure in an adaptive way, still introducing flexibility into play. Engage in other calming strategies. I was joking this morning that I've started going on a 3-mile. It's really a walk. I call it a jog sometimes, but it's like 95% walk, because that 5% where I jog, then I'm like, my knees hurt, my hips hurt, like everything hurts. But it's been the best thing I've done from a kind of a self-care standpoint. But figuring out what are those kind of places for your kids, which could include setting aside a worry time where all their worries they put to the side, or they can write and put in a little bag, and then you talk about them for 10 minutes in the day. So figuring out what those things are that work for your family and your kiddo can be helpful. And of course, taking care of yourself during, challenging time of COVID, but beyond this. Earlier this morning, I read one of my students' dissertations, which it was focused on fathers, but really that challenge of finding support. And I think this is incredibly difficult for all parents, especially moms who tend to get the burden of everything kind of put on their shoulders. All right, and then these just kind of list a few strategies. I really personally love the, kind of seek out meaning, seek out things that bring you happiness, and challenge kind of your expectation of having to do everything or having to be perfect on top of it, or on top of all. That there's an old kind of psychoanalyst who I would never recommend this book unless you want to fall asleep, because it would help with that. But the book, was essentially about being a good enough parent, and the whole idea that as long as you're not, being like awful, your kids are gonna do fine. They're gonna know that they're loved, and everything's gonna work out generally okay. And so, kind of keeping that philosophy that as long as you're hitting on that track, uh, everyone will manage successfully, and that having some me time can really help you, be even more present and effective in all the things that a parent has to do. All right, and then that is it. So I listed my email there, and I'll put it in the chat. But really, Sarah and I are always available for any questions or anything.
Eric, that was great. And I love Looney Tunes. Who doesn't love Looney Tunes? Hey.
I can't take credit. Anything that was cute in the slide set, one of my coordinators did, because quite frankly,
Well,
I'm
that
not
was
there, bud.
terrific. So we do have some questions, but for those of you, please fill out this survey. So I'm going to paste it again because, so let me paste the link. There it is again. So please fill out, it's just a few questions. Dr. Storch put in his email. So we do have some questions. Is it okay? Do you mind sharing either the PowerPoint or a PDF?
Sure.
Okay.
Yeah.
Okay. If you could email it to me, I will share it with the people who, so I will email it to you because I have everyone's email.
Okay. All right.
So if you email it to me, I will share it with you. And if I haven't, and if I, for some reason, because I wrote down everyone's name, but one person called in with a 405 phone number. So I'm not sure who you are. So if you want to private message me your name, please do so. And I will make sure that you get the presentation. But everyone else, I will make sure. And if for some reason you haven't gotten it in a few days, please email me and say, Judy, please send me Dr. Storch's PowerPoint, and I'll be happy to do that. So one person, does CBT work with nonverbal kids who use assistive communication device on a limited basis?
Mm-hmm.
It's
a terrific question.
I agree.
The short answer is yes. When you think about the behavioral principles that underlie kind of a cognitive behavioral therapy approach, it holds for everyone. Now, when we treat anxiety in my clinic, regardless of is it someone who's higher cognitive or lower or on the spectrum or not, we focus on the behavioral piece because I think that's where learning kind of comes into play. So like if you think of driving home from work, do you worry about getting in a car accident? Probably not. The reason behind that is that you've done it and it doesn't happen through that experience, and so there's no need to worry about it. On the flip side, say you got in a bunch of accidents because you're kind of a lousy driver, then you start worrying about that. So that experiential piece is really critical, and that's where the exposure comes into play. It helps kids learn that what they're afraid of happening doesn't happen and that they can't escape from it. So the whole idea of escape, or in the case of OCD, rituals, it becomes like a snowball effect where it gets worse and worse, with the idea being that you're reinforcing it. So same way that if a kid's being like mommy, 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 mom, and you pay attention whether it's positive or negative, you've kind of rewarded that behavior with your attention. The reduction of the distressing thing is likewise a reward. Now we don't do the cognitive stuff as much, and we become much more oriented towards the parent, kind of applying the intervention. And we also really want to bring in rewards that make people feel good and happy and kind of give a little bit of spice to life. So that's so short answer is it just becomes more behavioral, but yes,
okay,
we're very comfortable there.
Okay, thank you. Another question, and before I forget, in 2 weeks from today, Dr. Natalie Montfort will be talking about how do you explain diagnosis or diagnoses to your children? And this is really important. So even if you're not a parent, but maybe you are, I know we have several teachers and LSSPs on the phone. Maybe you're a social worker. Maybe you've had parents ask you, how do I explain a diagnosis to my child, or when do I do that? Dr. Monfort will be addressing that issue and those questions. So you'll be getting a flyer and an email about that as well. So the next question is, how do I, where was it? Selective mutism.
Ooh, yeah.
Does that work for someone who, does cognitive behavioral therapy work for someone who has selective mutism, nonverbal?
Yeah, it sure does. The difference that I've seen with SM is that uh, it takes a little bit longer, and a lot of times these kiddos are a little bit more reluctant to open up and speak. Um, and I'm smiling because I was thinking about the first SM case that I treated, where we just sort of counseled the parents, like the kid would point at everything, and this was a typical developing kiddo, and and um, and so they stopped accommodating, and at one point the kid like lost it, and the whole selective mutism broke, and the kid was pointing at the ketchup, and the parents were like, "You want the mustard? You want, like, I don't know what you want. I can't understand." And the kid's like, he blurted out, "I want the ketchup, damn it." And treatment success. But in most cases, it tends to be much more gradual. It takes a little bit longer. The exposure involves things like, it could start with, muttering consonants or small short words. The type of person can matter. So someone that's kind of warm and comfortable could be a little more challenging than someone who's not, or same age peer versus someone older. So, so with some of these problems, it just takes a little bit more to get progress. One of the things we really think about within our team and and across the field is really having a lot of just having a really warm, supportive group. So therapists that when you pick up, hop on Zoom with them, that they're excited to see you, they care about you, and that you're safe no matter what you do or say. And I think that part's really critical because we're basically saying we want you to face your fears and not run away from it. It's kind of a hard sell in that regard, but CBT can be very effective for kids with SM.
So 2 more questions. Someone sent me a private message. I have a young adult. He talks to himself a lot. Is this anxiety, or the term was used scripting? Which scripting, I know I've heard that term years ago, 20 years ago. Is that part of anxiety or scripting?
Hard to know. It could be one or the other. It could be both. So I've had people where they really kind of script out the interaction, and they're seen doing it, and it's a way of effectively sort of dealing with the situation before they enter it or while they're in it. The challenge is if it's that regard, can we kind of hold it in or do it a little differently so that one is able to engage a little bit more successfully. But yeah.
And it's really harmless, really.
Mm-hmm.
I mean,
right.
It's not hurting anybody.
Exactly. And look, we sort of all do this with, with all our interactions or all the, stuff we do at work, and, it may be only with the people with whom we're most comfortable that we're not, we're just laid out.
Exactly. Does CBT help children with lower functioning autism?
Mm-hmm. Yeah. So most of the studies have been with kids with who are high functioning, but I think that we're saying I think the behavioral principles can extend to those that that are nonverbal. I think when cognitive functioning starts going much lower, it becomes a little more challenging, and the behavioral kind of repetition elements that we see a lot with ABA can be really, really helpful here, and and for, for many others. What I like about the CBT approach is it's very kind of engaging, and it's all about a collaboration and partnership, where you're talking about here's why, here's what we want to do, and then how we implement it together.
Okay. Did I get everybody's questions? I think I did. Please type it in if I did not, but I think I did. I can't thank you enough. And you'll see, oh, I see another message. Oh, where can we get CBT? I'm sure you can get it at Baylor College of Medicine. Yeah, and check your insurance.
Mm-hmm.
And reach out to Dr. Storch. He's so accessible, so kind. And Sarah Weinzimmer, she put her email address as well, and she put her flyer. You'll see if you go up about 6 or 7 messages at 12:55 p.m. She put the Tele ASD flyer in there, and you can download that, and you can also reach out to me. I'm also on Facebook as Judy Blake. I post a lot of Baylor College of Medicine information. So if you're not on Facebook, and I totally understand why, some people aren't into that, but I post a lot of this information because I really want to educate our families. But I post a lot of this because I really believe in research. That's how we got to where we are today. So do you have any good recommendations for workbook and/or books to help elementary students with anxiety or ASD, anxiety and ASD?
Mm-hmm. Yes. So one of the ones that we actually use within our projects is something called Helping Your Anxious Child. And this is my favorite book that we've ever, that we're using our research, of course, but that I've ever read in my career. It's so simple and straightforward. And it's like
Helping Your Anxious Child?
Mm-hmm. Yep.
Okay.
It's just a nice, easy read.
Helping Your Anxious Child. Okay. You got that, Kimberly? Okay. And hopefully it doesn't cost a fortune.
Not at all.
Not at all. Okay. Yeah, by Ron Rappy?
Works for me.
Works for him. Okay. Very, very good. If there's anything else, feel free to reach out to Dr. Storch. I want to be respectful of everyone's time. I can't thank you enough. And Dr. Storch will be presenting again in a few months. He's going to focus specifically on obsessive compulsive disorder. I just think that is a really, what can I say, important topic for our families. I can't tell you the positive feedback I got, Eric, and people just thought you were terrific. Thank you for sharing the PowerPoint, and we so appreciate your expertise. Sarah Weinzimmer, you are wonderful. Thank you for being on. Sarah was asked to be on in case we had any glitches, because I wasn't sure how tech savvy Dr. Storch was. And we always need a really young person, younger than us, Dr. Storch. Definitely younger than me.
Young at heart.
Young at heart, that's right. So many thanks to all of you for joining us. And Dr. Storch, thank you for all that you do for our families. We truly, truly appreciate your time and all that you do.
My pleasure. Everyone have a good rest of the day. Stay safe. And anytime, just don't hesitate to drop us a line.
Thank you. Thank you for joining us. Many thanks to all of you. If there's anything I can do for you, you'll be getting an email from me, and please fill out that survey. Thank you all. Have a great day.
Okay. Bye.
Thank you, Sarah. Bye.